someone a co-host, then we can help
Okay,
let people in if you want, or you can just, yeah.
sure. I just added you. Perfect. Thank you. Okay. Awesome. All right, I'll go ahead and get started. Happy May, everyone. This is our Ivy Lab meeting for the month of May. We do have a new published manuscript, which is the Project Better, which is about outcomes at pregnancy to postpartum transition from a pilot clinical trial of a technology delivered intervention for birthing people receiving medication for opioid use disorder. And then we also have an accepted abstract slash poster, which is about substance use and mental health care utilization by pregnant and parenting people with cannabis use disorder. Our manuscripts in review is feasibility and alignment of actigraphy and sleep diary assessment in outpatients receiving buprenorphine for opioid use disorder, beyond once daily dosing, concordance between patient and provider reports of buprenorphine dosing frequency for opioid use disorder. We also have digital cognitive behavioral therapy, reduces heavy drinking among a non-treatment sample of people with alcohol use disorder, which is a feasibility trial with CBT4, CBT. And we have student voices on research training, a mixed method study on the research education needs of medical students. And lastly, we have within sex differences from a clinical trial of digital cognitive behavioral therapy for alcohol use disorder among a non-treatment sample. As far as our social media, here is our X page, our YouTube channel, which will also include this meeting for today, our LinkedIn, our Instagram. And here is our lab leads. We have Arjun in media, Dr. Madison Marcus for regulatory data. We have Amber Green and myself as coordinators. We have James Bacon for community engagement, Michelle E. for interventionist. We have Dr. Austin Jones for regulatory data. And we also have Nicole Boss as an interventionist and data regulatory. For the project SORT, this is one of our studies that is about sleep and opioid use disorder recovery, and it's led by Nicole Boss. Our registry study tracks clinical outcomes of pregnant and postpartum patients from our OB Motivate clinic, and it's led by myself. CBTIO is a study about cognitive behavioral therapy for insomnia with patients with opioid use disorder, and it's led by Michelle E. and Amber Green. And Luborexant 2.0 study is about a medication treatment study testing the effects of Luborexant on insomnia and impulsivity among people with opioid use disorder. And it's led by both Doctors Austin Jones and Madison Marcus and Kaylee Swan. Suvorexant is also led by Doctors Austin Jones and Madison Marcus. It's a phase 3 double-blind randomized controlled trial of suvorexant versus placebo on insomnia among people with opioid use disorder. Project Castle is led by Amber Green, and it's about a computerized intervention that educates pre-medical professionals on substance use disorder stigma. Some of our educational studies includes the clinical research curriculum, which is led by Dr. Austin Jones and Amber and Nicole Boss. First Steps, which is formerly the Jeffers Project, addresses maternal morbidity and mortality by adapting a patient navigation model for birthing people with substance use disorder. The items in pink include some of the things that First Steps has already completed and or submitted. And it's led by James Bacon and Nicole Boss. As far as our next lab meeting in June, please be on the lookout for my email announcement. And thanks again, everyone, for being flexible this morning with our meeting link. Thank you again for your time. Here is my email if you have any questions or would like to present any other updates. And now I would like to pass it over to our special presentations for today. I think, Madison, you wanted to start.
No, I want to reverse order that.
Okay,
Yeah. I'm
sounds good.
calling Nicole and then Austin, and then if we have time, Madison. Yeah, that's my request.
Sounds good, Nicole. I'll let you take it away. I'll stop sharing.
Okay. Can you see my screen or do I need to reshare? Let's see. Okay.
Reshare.
Okay, now?
Yes, you're good.
Okay, cool. So, hi everyone. I'm just gonna do the whole spiel. So just pretend you're at CPDD. And I'm gonna be a co-lead for the panel. So I'm gonna be like, hi, I'm Nicole. I'm a clinical psychology PhD student at VCU. I'm really excited to be part of this panel. The other speakers have been so excellent. Today I'm gonna be presenting something from, I already fucked up, guys, sorry. See, if I don't follow the exact script, this is why I have to practice until I can do it in a blackout. Because if I don't follow the exact script, I just get so thrown. So the title of my presentation is Drug Use Trends in a Sample of Individuals Engaged in Standalone Digital Cognitive Behavior Therapy for Alcohol Use Disorder. The title rolls right off the tongue, I would say. Um, Okay, so we did not have any disclosures to report. The PI from this study, she actually did this for her dissertation, which is amazing because it's a RCT. And she was able to get a lot of different kind of small seed grants. And so these are all listed here because we really appreciate being able to do this research, and the funding is what makes that possible. So I'm going to start with a little bit of background about the kind of context and literature for this study. So as I would imagine comes as no surprise to you in the audience, alcohol use disorder is the most common substance use disorder. About 29 million people in the United States have a lifetime history of AUD. And among this group, so among people with alcohol use disorder, drug use is really common. So that looks like about 30 to 40% in different samples of people with AUD also use substances. And so probably, again, is no surprise, for that like 29 million people with alcohol use disorder, about 8 million a year access or utilize treatment. And so this really highlights most people with AUD are not getting treatment for AUD. And so we need accessible, scalable interventions. And one promising modality of intervention that we hope can provide increased access and utilization for people is through digital health interventions. So these are online treatments, app-based treatments. And so far, the research is pretty promising in terms of effectiveness. Generally, the trend is that there are alcohol use reductions in relation to digital health interventions broadly. But what we haven't really looked at is whether there are kind of concurrent substance use changes during alcohol use treatment in these digital health interventions. So we know that substance use is elevated among people with alcohol use disorder compared to those without alcohol use disorder. We know that interventions generally provided online can help reduce alcohol use, but what we haven't looked at is whether or not there's concurrent drug use changes. And so this study, I wanted to investigate that. So to see if there's changes in time in drug use in a community sample of individuals enrolled in a clinical trial assessing digital cognitive behavior therapy, which I'll call probably CBT for CBT, through some of this presentation for alcohol use disorder. So we recruited our participants from researchmatch.com. And when I go through the discussion, I'll kind of provide some more detail about what that might mean for contextualizing our results. The first thing that participants did that were interested, they went through an online screener for those that were eligible. They completed a consent process. The study was explained to them online, and then they completed a baseline survey. So this is a simple diagram of the study components and time points. So as I just said, that first time point is this baseline assessment. They complete a survey, and then someone from the research team, so one of the research team members, called participants and made sure that they understood the remaining parts of the study, let them ask questions. We also compensated them for their participation in the baseline. And during this phone call, we randomized participants in a 3-to-1 ratio, 3 in treatment, 1 in the assessment-only group. Then there was an 8-week study condition period, followed by a post-intervention assessment. And then finally, 4 weeks after the post-intervention assessment, so 12 weeks from the baseline assessment, we did a 1-month follow-up. Just to provide briefly kind of what CBT for CBT is, generally, it stands for computer-based training for cognitive behavior therapy. It's a 7-session, all online, kind of participant-directed treatment. It really is based off this kind of triangle of CBT. Thoughts are related to feelings, are related to behaviors, are related to thoughts. So we do some psychoeducation in CBT for CBT about that relationship. A lot of the treatment focuses on really tangible skill building. So how people can say no to alcohol, strategies to reduce use, coping mechanisms. So we collected at baseline kind of general demographic information. Then we did timeline followbacks at both at baseline, post-intervention, and 1 month to kind of capture that substance use. For this analysis, I did % of days of substance use over the past month. And then for the alcohol use variable, I did number of drinks per day. And I will kind of describe these variables in more detail when I talk about the model that we built, because I want it to be fresh in your mind. So for the analysis, I did some descriptive statistics. I want you guys to be able to kind of know what this sample looked like and who they were. We'll talk about what substance use at baseline looked like. And then I'm going to discuss the random effects regression that we use to examine change in percentage of days of drug use over time. Okay, so I was thinking about this morning. I'm breaking the fourth wall or whatever the thing is, because I want your opinion on this. So I was thinking I should probably split this into 2 slides. One where I briefly go through the sample, like age, blah, 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 all the stuff you would expect to hear in a kind of brief presentation. And then I was thinking I probably should have a slide that follows this that goes through AUD severity. And then I think at that point, it would also make sense for me to introduce the WHO risk levels, because I use them in the regression. And I think as the presentation is right now, it feels kind of like out of nowhere that I'm introducing this thing. And so when I was practicing, it feels like to me that this next slide that I'm going to go through should actually be an alcohol use disorder and alcohol use risk level at different time points slide, so that I can kind of ground the audience in what that looked like. So pretend that's in here on that I just did that, or don't, and tell me what you think about. Tell me if you think that the slide about the regression makes sense without me having provided the additional WHO risk context. So on this slide, I have some visuals about the substance use patterns of the participants in our sample. So I would have told you guys that about 36%, between 36 and 37% of our sample reported lifetime history of substance use. The most commonly used substance was cannabis, followed by benzodiazepines, then opioids, and then stimulants. For our mixed effects regression, okay, so the box that has the kind of yellow titling independent variables, I want to walk us through that. So one of the variables that we looked at was randomization group, so CBT for CBT versus control. Then I also looked at time, and then we built an interaction term, so randomization times time. We also added alcohol use by WHO risk level at baseline, post-intervention, and 1 month follow-up. And then finally, a term for alcohol use times time. The dependent variable was change in % of days of drug use from baseline to post-intervention and 1 month follow-up. And so we found that the overall model was significant. The % of days participants used drugs significantly decreased in both groups over time. And this relationship was not related to alcohol use. So as participants reduced their alcohol use, we also found that participants reduced their substance use. And you can see in the bottom boxes here that the control group used substances more regularly than the treatment group at baseline, but both groups reduced their substances by about 10% in terms of days per month by the end of the intervention. And so I want you guys to pretend that I have a really nice graph here, 2 lines, one for CBT and one for the control group, looking at drug use across the time points with alcohol use as kind of the other independent variable. Okay, so pretend you're looking at that. It's very cute. And then I'll say, so we've found kind of in accordance with existing research that CBT for CBT helps reduce alcohol use and AUD severity, both as a standalone treatment, which is what kind of the parent study of this looked at, and as a supplement to traditional AUD treatment. This study adds to that literature by kind of suggesting that alcohol use reductions in this sample weren't associated with the increase of frequency of concurrent drug use. And while both treatment and control groups reduced their frequency of drug use, there was no difference between the groups with CBT versus the control group. So we did not see a kind of treatment effect for a reduction in substance use. I would like to highlight, though, that I think we're kind of potentially missing an opportunity as interventionists and researchers to acknowledge the literature in that a lot of people with alcohol use disorder use substances, and we're not kind of embedding transdiagnostic treatment mechanisms that we know work within treatment. So, for example, in CBT for CBT, there could be some tools and tricks that we provide patients regarding cannabis use, right? We don't have to change the focus of the treatment, but implementing examples from people's experiences could be a kind of exciting future direction. Like, does this impact other people's concurrent substance use as we target alcohol use? And the last thing that I'll touch on today is some limitations from the study. So we know that people from Research Match are motivated. It's a little bit older of a sample, more educated. And so we have to consider our results with that limitation. This is also a secondary analysis. The PI, I think, did a really good job of collecting a rich data set, but the study wasn't powered for this specific analysis. And we need more nuanced measurement of alcohol use and drug use changes over time. And one thing that I was kind of thinking about as I was creating this presentation and doing this analysis is like, it could be a very interesting study to examine kind of session by session changes in drug and alcohol use using some like EMA tools. So we're combining like novel online treatments with more momentary assessments and what that looks like. But I want to thank everyone for being here and for inviting me to be part of this panel. And I will take a few questions. Okay.
Great job, Nicole. I will start things off, but I do encourage people to give feedback to Nicole. Please. I think it was great. I think your slides are very pretty. I agree with what you said about splitting. I'm all about one graph, one table per slide. Like, they're not limiting you to the number of slides, right? You're limited by time. So who cares if you have 20 slides if you put like one thing on each side? You know what I'm saying? So I'm all about that. And then on the note of what you were talking about with that, I think of the AUD is like a descriptor of your sample because that's a DSM-5 diagnosis, right? And then the WHO drinking levels are the outcomes. So those are two distinct things. And I think keeping them, describing them as such. So if you do put them on one slide, being like, this is how we describe our sample. These were the primary outcomes that were looked. This is the primary outcome was the WHO drinking levels that were looked at in this clinical trial. I think delineating those are different because it really is, right? One was used for eligibility and one was used for outcome measurement. Just to answer your question, at least from my perspective. And then the kind of main advice, the one thing I will say, and I'll let others speak up, is great job. but I'm giving you constructive feedback because I know you're good with that. I feel like the research question isn't as apparent at the very beginning, and I would reorient your audience. So like I got an urgent text message from Liz Fortune during your presentation, and I did it and I came back and I know what your project is, but I was like, whoa, I missed your results, I missed these things. So you want to reorient people throughout back to your aim one, back to your aim two. There's no, you can't repeat your research question and your aims and what your independent dependent variable is too many times in a presentation to keep people oriented. Um, and then okay, sorry, then one more thing. This might be a little controversial, so you might not agree with me, and that's okay. But at the very beginning, like you kind of like you sneak peek us. You're like, ooh, this is a secondary analysis of a clinical trial. And we're like, oh my gosh, a clinical trial. Love it. And like, so you sneak peek at the beginning about it. I don't know. I personally think that you should bring up towards the very beginning what the take-home finding was from Annabeth's clinical trial. We found that drinking got better. Like you don't have to go into all the specifics, but like generally they found that it worked, right? So just I would think you should sneak peek because I think that then dives more into the rationale for your study, which was like, hey, drinking gets better. We even found it got better in certain ways. I know it was a little nuanced, certain ways with the CBT for CBT clinical trial. The focus of this project is on this really important other topic that hasn't been looked at as much. I actually think bringing that into your background makes it more clear what is known and what is not known. And then you can focus on that not known because that's your research question.
That is such good advice. Thank you. Yes,
Oh,
we have
thank you.
this idea. No, why didn't I? Yeah, that's like, yeah, we found that there was a treatment effect that people in the CBT for CBT reduced alcohol use over time. And so I can cite that. Thank you.
Okay, I'm going to stop and let others give you feedback.
Nicole, amazing job. Love the picture of Rosie at the end. And I see you drinking out of the coffee mug I made you. And so I am feeling really flattered. Okay. Amazing presentation. I am just always in awe of your stats prowess. I think one thing that could be helpful is I don't know if you had this, but like what Caitlin was saying, an objective slide, like right before the results, just to be like, this is specifically what like my research question. And then after the results, like reminding people of like what that objective was before you go into the discussion and kind of how the discussion mapped on to the objectives. Um, Me personally, I don't know stats that well. So I'm like, okay, a mixed effects regression, really fancy. What does it do? Like, what does it measure? So maybe like a sentence for the stats dummies in the audience of like what this specific analysis does would be helpful. Um and those were, I mean, honestly, like it was a great presentation. Those are my couple points of feedback.
Thank you. And I feel like you think I'm good at statistics and it makes my head so big. Thank you so much. But the reason I don't like describing them is because I know someone who actually knows statistics is going to be like, actually, that's not what that is. But I'm going to give it a go and I'll try because I appreciate it. And I think you're right. Because then people will understand more what it means if I describe what it does.
Exactly.
I had a comment. Nicole, it's such a great presentation. One of my favorite things about it was that the colors. I think sometimes we're so used to very specific colors for presentations. The black and the like golden yellow orange really like made things pop. So I just wanted to say I really like that.
Thank you. That unfortunately does matter so much to me. So I appreciate it.
Yeah. And then I know on the slide about the descriptions with like you were asking the question about putting those two graphs on different slides. I know the descriptive one that was on the left. I think you should actually add a graph too with that. I think that would be nice as you like go into each descriptor.
Thank you.
I had like just not really like a critique or anything, mainly just to kind of point out. I think one of the best or like the better thing that you did for this was something that I just always it always gets pointed out, or I just notice it more, is the translation. Being able to translate a concept of high like scientific like rigor, or just like, just it's not something that every single person knows. And even saying basic terms that people in the science field know, a lot of times people in the science field just know that that's a term, and it's like that doesn't necessarily mean they know what it is inside and out. So translating something that's complex to be able to be like you're just telling a story, not something that needs to be like accepted by Yale, not something where you're opening a thesaurus and everything that you do is just you're reading a thesaurus to try to sound super grandiose or whatever. You took a concept and were able to explain it across any audience, which I think is like a goal, or like I always like try to make that happen. Whether or not that I successfully do it, different story. But that's always what I try to like emphasize. And I thought that you did like a incredibly good job compared to like other people I saw like farm school, like all that stuff. So like, that was really, really impressive.
Thank you, Austin. That's so nice.
Okay. Any last feedback for Nicole before we go on to Austin? Some job, Nicole. You're ready. Well, almost. You incorporate the feedback, then you'll be ready. Austin, you're up.
Let me share the screen. Okay, go to, oh, what? Keeps getting flipped on me because I had to change the order or flip my monitors actually physically because the cord was getting snug. So I get confused on which side the monitor is now.
We see it, but
Yay!
it's
Perfect.
very
Okay.
small. So if it's
That
possible, yes,
that
that's good.
better.
It's still small, so I think either you can zoom in on the different
Mm-hmm.
areas you're
Yep.
talking about. You can,
Mm-hmm.
if you're able to do that. I mean, I know I can do it myself on my Zoom, but
Yep. I'm definitely able to do that.
it's
So
hard with the
that's
posters.
right. Yeah. So that'll be my goal here. Okay. So
Okay, so just so reorient everyone for
yeah.
feedback, Austin has a poster. So you are gonna do your succinct poster pitch,
Mm-hmm.
and then
Yep.
he's gonna take questions. And so the whole point of a poster presentation is for you go up, you get the quick poster pitch, and then you follow up with a lot of detailed questions thereafter. So it's different to what Nicole did, where there is a set amount of time she can present, and then she does have time for questions at the end. So just orienting people who don't do this all the time.
Yep. All right. All right. So, hello, everybody. So, as Dr. Martin has just said, I'll be going over my CPDD poster, which is focusing on the safety and tolerability of Auvelity, a medication currently on market. As an adjunctive medication in adults with opioid use disorder who are maintained on buprenorphine. So let me get let me there we go. Okay. There we go. So, just a kind of brief context, the opioid use disorder remains a major public health issue. And even though people who are on medication to help with opioid use disorder, we still see treatment discontinuation and return to use, and it's common among this population. And another issue with this population is that we also see mood-related symptoms, and of these mood-related symptoms, we see that people with OUD have depressive symptoms and negative emotionality, and it's common among this group, and that they have been linked to worsened outcomes within buprenorphine treatment. So for Auvelity, the drug of interest for my poster, Auvelity is a medication which is a combination of dextromethorphan and bupropion. And this medication may be relevant to the population because it engages with pathways that are related to mood and reinforcement. But before we study the broader clinical context and the clinical effects of this medication, the first step we want to do is to determine whether Auvelity could be safely co-administered with maintenance buprenorphine, which brings me to the overall objectives of this study or of this poster, which is where we sought out to evaluate the short-term safety and tolerability of Auvelity being co-administered with buprenorphine, which includes looking at adverse effects, looking at physiologic safety concerns and measures, and then also looking at subjective outcomes like craving and withdrawal. And we want to see if those differed between participants who are receiving Auvelity versus participants who are receiving placebo. So for this study, it was a phase 1b to a clinical trial, which was a randomized trial that was double-blinded and placebo-controlled. It was randomized, or the participants within this study were randomized 2-to-1 to Auvelity or placebo. So we had 2 participants on Auvelity for every 1 participant on placebo. And we also, for this study, eligible participants were those who were between ages 18 to 65, and were those who had opioid use disorder and were stable on buprenorphine. So for the measures that were the primary measures used, we looked at the baseline safety assessment. So we did baseline safety assessments or day 0. And actually, let me move it over here so we get a better look. So for the study design, briefly, we looked at safety assessments. We did those on baseline, and then before they started the study medication, then they would have daily dosing of the study medication, Auvelity or placebo, which they had once daily for days 1 through 3. Then they increased to twice daily from days 4 through 7, followed by a repeating of those safety assessments that were done at day 0. They were just repeated again at day 8. And so for the main outcomes, as I had mentioned, they were looking at adverse events, the physiologic safety concerns, with also secondary outcome measures that focused on withdrawal, craving, drug effect ratings, depression, and anxiety. And we look at depression and anxiety here because bupropion, one of the medications that is used in the combination of Auvelity, is an antidepressant. So we want to just make sure that there are no increase or depression-like symptoms, or if that has been monitored or modulated by this medication. And we also looked at anxiety, which I will go into more later on when we go through the results. So for the overall results here, the primary analysis included 18 participants, 12 who were on Auvelity, 6 who were in placebo. For this treatment group, or for the participant characteristics, we saw that the average age for the participants in the study were 43, and most of the participants were male, and most of them received sublingual buprenorphine. For our primary safety results, we saw that there were 0 serious adverse events. And for the total adverse events, there was a total of 53, which was a combination of both the Auvelity and the placebo groups. And we also found that there was no overall physiologic safety concerns. For the physiological safety concerns specifically, we evaluated those repeated vital signs that were done at day 0 and day 8. And they included blood pressure, both systolic and diastolic, pulse, respiratory rate, as well as pulse oximetry. And these graphs here at the bottom are just some examples of the total amount of vital sign graphs that we have. So these include the systolic and diastolic blood pressures, where they include the red lines are the Auvelity treated participants, and the blue lines are the placebo treated participants. The blue lines and red lines include both baseline measures and day 8 measures. and they were measured across the different time points collected at day 0 or baseline and day 8. And so for here, what we see is when we looked at whether these vital signs or were changed, or if they were differently across the study days and time points. When we looked at that, we did not see any significant or concerning differences between Auvelity and placebo-treated groups. So we did not see any increase or any physiological safety concerns across all the vital signs here. But right now, I just have the blood pressure graphs on my poster, but I can go into more of those if you would like. For the adverse events, when we were looking at those total 53 adverse events, they were very similarly split between the different groups, where there were 27 adverse events reported in the Auvelity groups and 26 reported in the placebo groups. And the severity of all of these adverse events reported between both groups were very similar in their severity across. And the most common adverse event category that we found within this were gastrointestinal, things like nausea, nervous system, so things like drowsiness or headaches, as well as psychiatric events. So those are the top 3. Psychiatric events include irritability or anxiety. The overall, we saw that the adverse events were again very similar in the number as well as the severity between the different groups, between Auvelity and placebo. And the profile that we saw did not suggest a clear tolerability concern with the Auvelity compared to placebo. Then when we also looked at the additional subjective outcomes, we were also reassured that there was no significant effect or concern, as we saw that there was no worsening in withdrawal, craving, good or bad drug effects, or depressive symptoms or anxiety measured from the GAD-7. And we looked at these medications and looked at them across the various days, because from day 0 all the way to day 8, we compared across there and still saw no significant concern or no clinical concern on any of the subjective effects or physiologic safety concerns. So overall, the adjunctive Auvelity was well tolerated in buprenorphine maintained adults with opioid use disorder. We saw that there were no serious side effects or serious adverse events, no physiologic safety concerns, and the adverse event severity was very similar, as well as the number of adverse events between the Auvelity and placebo-treated groups. And with everything together, these findings support continued evaluation of Auvelity and buprenorphine co-administration in larger and longer studies to evaluate them more and to evaluate more of the broader clinical effects. And so with that, I'll be happy to take any questions.
Yay, Austin, that was great. I'm sending you some feedback. Um, one that I wrote out, but I feel like I'll say it for the group because it's kind of the MO of a lot of our projects,
Mm-hmm.
is for your like background when you're setting people up. I think it can be a little bit more succinct. And also, I think kind of like when I was telling Nicole, I think you can bring toward the front
Mm-hmm.
that Auvelity is already FDA approved on the market medication
Okay.
because that puts people when you're presenting a clinical trial,
Mm-hmm.
there's different like framework like I go into a different headspace. Like if you're talking to me like about like an investigational compound, a phase 1 trial, like my brain goes one way
Mm-hmm.
versus a clinical trial like this, like already FDA approved med, we're looking at it just in a different patient population. My brain goes a different space. And Madison's nodding her head because this, like for people who write IND applications, we have to do all this IND stuff. That's kind of like the bubbles that we think about things. So if a clinical trial person is coming up to you, talking to you about your poster, I think you need to bring that up to the front. And
Gotcha.
so I think you can be like, I think most people are going to know what OUD is. So I think you can skip that and just say like medications for opioid use disorder, they work. We love them, like buprenorphine and methadone. However, a big chunk of people still drop out of treatment or have substance use recurrence, like around 60% based in studies. And we know that one major contributing factor to those poor outcomes or areas that we could do better are underlying mechanisms of comorbid things like depression, anxiety, etc. And so we looked at FDA approved medication already on the market for depression, and we looked at that in this patient population of patients on Suboxone to try to see if it's worth looking at in future trials as a way to improve outcomes.
Hmm.
Boom, now go to your objective. So you're kind of bringing in the FDA approval and making it more succinct for your rationale for your study.
Gotcha. Makes sense.
But great job.
Yeah, super great job, Austin. And your poster is really pretty. I love the color scheme. I hate the color scheme of mine. I want to change it. So this is inspirational for me. Um, but I was gonna say, yeah, kind of similar to Dr. Martin. Like people kind of like the motivation for the trial is pr something that's pretty easily understood by a lot of people who are gonna come see your posters. So probably you don't need to spend as much time on the background. I mean, maybe if, somebody tells you their background or they need a little bit more, you can kind of tailor it. Um, but yeah, I think that's a spot where you could definitely cut out a lot of time. Just because like with the posters, it's so easy to say. I'm having the exact same problem with mine. So like, but like just I try to keep it around like 5 minutes max.
That's what I was
Um,
trying so hard to do.
I know.
I was
Mine
like
is 10
45
minutes
seconds, 40.
right
Yeah.
now too. Like, yeah, but just some as an outside perspective, some spots where you can maybe cut down. I think the
Mhm.
background is definitely one of them.
Gotcha.
And then I think there are some spots where you can kind of, instead of going through like the flow, how you have it laid out in the poster and kind
Hmm.
of like how it is with the paper with like design, results, discussion, you can kind of jump around a little bit more in a poster. And sometimes that works for me. And kind of starting off with like just telling people up front, like the main takeaway. So like, we looked at the primary safety results. Overall, we saw that it was pretty safe. And then kind of getting into a couple like more granular data points.
Hmm.
Um, and then like with the physiological measures, like you maybe even don't need to mention that you took like blood draws at baseline and the
Right.
final day until you get to that, because that's the first time that it really like comes up in the data.
Hmm.
And then like talking about like a little bit more after you go into like the 53 total adverse events, then like right after that, breaking it down a little bit more how you have it on
Gotcha.
the adverse events.
Mhm.
Um,
Gotcha.
so I don't know, see what works for you, but
Yeah.
sometimes that helps me to just kind of like break out of like the paper flow
Hmm.
and just think about if I'm having a conversation with this person, how would I
Hmm.
kind of tell them about what I saw? Like very
Right.
conversational.
Right. Yeah. I feel like at least with like in person, whenever you do poster presentations, it's a lot easier when you have the whole thing like right there. And then because like you said, I'm more prone to doing the jumping around and like pointing out the things when it's in person because then it's like I
Yeah,
don't have to do that
definitely.
zoom in on the but like it is but I did set it up to try to go in order, but I do see what you mean because I was just doing that from manuscript mentality of being like going in that order. So yeah, I think it'll be easier when it's in person, but I'll still like try be like or focus more on like just explaining it in like a logical like you mentioned these things and you mentioned this instead of just the natural state of what a manuscript does.
Yeah, and it's so hard, like after you've already written the full manuscript to then like take a step. Like it's good because you know a lot about it, but it's
Hmm.
it's really hard to like zoom back out,
Hmm.
to like drop a lot of details that people
Right.
can kind of ask follow-up questions about.
Hmm. Hmm.
Anyone else have feedback for Austin? Great job. Madison, do you want to quickly do yours or do you want to save yours for like a longer presentation at a future lab meeting? But it probably would be after CPDD. That's up to you.
I can save mine for later. It's like, yeah, I did do like exactly what I'm talking about with Austin. Like, it's about like 10 minutes long for like lab meeting presentation, and then I'm yeah, trying to cut that back for CPDD. So I don't want to hold everyone up.
Are you sure?
Yeah.
Okay, I just
I'm
want to
happy to
make,
practice with you at like a different time too, so I can get some
yeah,
feedback.
yeah. And yours is a full paper and it could be a whole lab meeting just to share. I think it would be a great for us to have a whole lab meeting for that presentation later, especially because it is related to all of our sleep studies that we're
Yeah.
doing. So I think it would be, I think it'd be good to have as a longer, but I just want to make sure you feel comfortable practicing wise.
Yeah, I'll find another time to practice with a small group.
Cool. Awesome. Well, great job, everyone. CPTD will be fun. It'll be here before we know it. Anything else, Michelle? Michelle C. C.
No, I didn't have anything else. Thanks,
Okay.
guys.
Awesome. Thanks, everyone.